Hey everybody, welcome to this week's episode of the Patty G Show. We are checking in on our health. We're doing a little pulse check. That's right, we're diving under the lens and behind the stethoscope with Dr. Sasser and really having a great conversation around healthcare as a whole in the U.S. and global. It's a very interesting conversation with Dr. Sasser upcoming here in just a minute. Before we get to the episode, I want to give a big, wonderful thank you and shout out to the folks that bring you this show each and every week. Falaya Real Estate, Lakeman's Health Center, Cortex, PB&J Productions. Enjoy the show. You're out by Carriages.
Yes.
Okay. So let's back up. Let's figure out how you got there. So.
Yeah. So, when we first really started the practice, we were over on Bluebonnet.
Okay.
And it was a good space for us. We were kind of getting to a point where we were looking at maybe needing a little more room, but fate kind of pushed us faster. That the landlord decided they wanted to expand into that space, and at the time, the garden type offices in Baton Rouge, that, a small primary care or dentist, they were very hard to come by. And we looked and looked and looked, and we ended up having to do, cobble together like 4 executive offices, just to make it work. And then just, kind of out of nowhere, the space we're in now opened up. It was formerly Dr. Hill's office. He was not a practicing physician, but that was his business office. And it's a unique layout that would not fit a lot of people, certainly not a lot of medical practices. But it's perfect for me. That my office would probably be subdivided into 2, maybe 3 offices.
Oh wow, big space.
Very big space, but that's how I like it. That I don't meet patients in the clinic room. That I find that it changes the dynamic real fast. Of I'm here to tell you what to do, and when we're sitting there, having more of a business meeting, that it lets patients kind of express, this is what I want to do. This is not what I want to do. And, it's your body. That's your choice. And it's much more helpful of, when you go the other direction, you can make a perfect plan, and that's wonderful. But if in the patient's mind the whole time, they're thinking, I'm not doing any of that. When I, go a few months down the road and I'm trying to look at data points to figure out how we're doing, well, if they're not on board with this plan, then all of it's meaningless.
Right.
So I would much rather somebody tell me, this is what I want. This is what I'm comfortable with. And instead of 100% plan, I make an 85% plan, but that we're both in agreement. And I just feel having that dynamic right off the bat, when you're sitting on an exam table, you just, you feel like you're at a zoo or something.
Yeah. Tell me what's wrong, Doc.
Yeah. And it just immediately sets in this, paternalistic, I'm on a different level than you. And that's not what I like at all. So just the space just translates to what we do really well. So, we've been really happy there.
So what did you do? We'll get into kind of the history of the space that you're in and the practice that you're doing. What was your experience before that kind of led up to this?
So out of college, I went in the military. I was initially in the Marine Corps, and went through flight school, and I flew Cobras for the Marine Corps for some years, and then had an opportunity to transition, and I moved over to the Air Force side, and I got to train in the F-15 for a little bit, and kind of hit the end of that road, and was didn't know what was next. And I knew I didn't want to go to the airlines. I knew I didn't want to, do staff work. I used to have a very high-minded story of how I chose medicine, which was completely untrue. That in the true story was I was, laying on my couch on a Saturday of like, what next?
Yeah.
And I'm flipping through channels and I start watching that show Scrubs. And I was like, maybe I'll go to med school.
Scrubs make you want to go to med school?
That was why I decided to go to med school. I'm like, that sounds fun. My original degree was in political science. I had no science background. So I had to go back to LSU, started off, biology 1201.
Wow.
Took me 2 years to get through the prereqs, and then applied and worked out, got into LSU New Orleans, did my medical school there and did my internal medicine residency there as well. And coming out of residency, I took a position with Lake Physicians Group, and was there for 4 or 5 years, I guess. And, it was being a physician's tough these days. I have, friends who they reach out, their kids are interested in medicine. And, if it's something you have a passion for, then that's wonderful. But just kind of as a default, it ain't what it used to be. You get in about 6 months and you realize the realities of what it really is. Modern medicine, the reimbursement rates are fairly flat for over 20 years. While the overhead and most of it's coming from dealing with insurance, has continued to skyrocket. So the only variable in the equation is the number of patients. Quantity is the game. So when you get into practice, you need to have 3,000 to 4,000 patients on your census, and you need to see
4,000.
Yep, assigned to you. 3,000 is kind of the magic number, and that puts you somewhere at 25 to 30 patients a day. When I would leave, I would get in my truck, and so many days I would sit there and I'd be like, God, I know I made mistakes. Please tell me they weren't bad. Just there's so much data flowing at you. It's hard. I sympathize with, the guys that are just in that system. They want to be good doctors, but they're not really allowed to be. It's just crank out the patients. I'd heard about this model, and started looking at it. There was a guy that I'd worked with at the lake that had started a practice, and he and I worked together for a few months, and we had very different visions. So I moved on to start my own practice. It's been 5.5 years now.
Wow.
And when I first started, I had 4 patients. And, I did moonlighting in hospitals and made money to keep it afloat, and just stuck with it.
So on the traditional model, you're right. It's a lot of data coming at you. And I mean, to be able to juggle going from one patient room to another patient room with maybe 10 minutes per patient.
9 on average.
9 minutes. So in 9 minutes, the expectation is they're supposed to read your chart, understand your history, get an explanation for what you're in for today, what the plan, what the path, whatever it may be. If you've got x-rays or whatever it is, they got to look through that, and then build some type of bedside manner with you, and then either come to a diagnosis, a treatment plan, whatever it may be, in 9 minutes.
And what it turns into, and it gets into the economics of medicine, is you rely on diagnostics and referrals. So this sounds cardiac. It sounds vaguely complicated. it's well within my scope of training. I understand it, but I simply don't have the time. So let me send you to cardiology.
9 minutes.
So when you look at direct primary care and you know, direct primary care is a national model. You know, I'd love to pretend I came up with it. I didn't. Nationally, it's a big thing. It just really has not taken off locally. But with that model, when people study it, the big difference that it makes is the downstream costs. So lower reliance on diagnostics, lower reflex referrals, letting a well-trained internist practice medicine. When you're saddled with 9 minutes, it's not that you don't know what to do, it's that you don't have the time.
Right.
And that bleeds over to the specialist as well. So everybody's just kind of, you know, making shotgun approaches, ordering a lot of labs, ordering a lot of imaging, and waiting for reports to come back, and you look and see what's in red. And, you know, it's taking, you know, these highly trained, intelligent physicians and turning them into kiosks is basically what's happening. And all of that's expensive.
Right. Because then once that happens, you, like you said, you've got the whole administrative side has to go back, bill insurance, collect on that. And they have to do that for if you've got only one physician in that building seeing 24 to 30 patients a day, but you probably don't. You probably have maybe 5 or 6. I don't know how many are on average.
Depends.
But, you know, you've got a multiple of that now that they have to see about.
Well, it's, you know, when we say concierge, you know, people come up with one image in their mind. But what we're really saying is small patient panel. So, you know, I said, you know, 3,000 to 4,000 patient panel is, you know, fairly standard for an internist. With concierge, we're talking about 500 to 800 patients. With the traditional concierge model, which, you know, there are, you know, multiple practices here in Baton Rouge that use that model, they still fully participate in insurance. So they still bill insurance. They still have to file claims. Patients still pay their copays and deductibles. So the way they get from 3,000 to 500 is, in addition to billing, then they charge a monthly fee to be a part of their clinic. So their way to reduce it is by increasing revenue. Direct primary care takes the opposite approach. It attacks overhead. So in a standard primary care practice, the studies put it somewhere between 50 and 70% of your total overhead is insurance administration, just trying to get paid.
50 to 60
to 70.
Wow.
Just trying to get paid. So if you step out of insurance, now you have reduced your overhead so much that you can take your patient panel down to that 500 number and your revenue's the same because you've cut out all of this massive overhead.
Yeah.
So it's just two different approaches, revenue versus overhead, but both getting to smaller patient panels so you can do quality of care. The positives to direct primary care, in my opinion, is when you step away from insurance, then it starts opening up a whole lot of other opportunities. So I have a license to dispense my own medication. So when I write a prescription, we fill it right in clinic. Wholesale cost. We contract out, we contract labs. So a standard annual lab, you know, the normal labs we get every year on folks that run, you know, $300-400, costs us about $20. We just have a direct contract. They bill us directly and we pay them and just bill the patient for it. And we do that with imaging. You know, an MRI bills out around $2,000. Depending on the study, we pay somewhere between $300 and $400 for it. So it opens us up to do, you know, a whole lot of other things that if we're involved in insurance, there's no reason or benefit to doing that.
So is it just because of the heightened cost of administration on the insurance side they have to charge so much?
Yeah. I mean, when I contract with a facility, I reach out to them, and what I've kind of found over time is if it's more than a 5-minute conversation, I have the wrong person, because it's not the message, it's not the deal. Anyone who understands what I'm suggesting to them will take that in a heartbeat. We pay, we use a benchmark, and we pay a percentage over that benchmark for any service they do. So for imaging, this is the benchmark. We pay you this percentage above it. And anyone in a clinic who really understands how much is lost in the churn of insurance, of denials and appeals, and just downright just don't pay them, that's lost, they're more than happy to take that lower amount knowing they're getting paid.
Yeah. And so not having to spend the overhead.
Not having to spend all the overhead on dealing with all the billing, and just, one of the very frequent denial codes that you would see, it's the code is for requires more information. And I was actually, for a while, I handled denials for our group. I'm not sure if that was a compliment that they nominated me for that. But I'd call these folks and be like, well, what information? I don't know, just more. Like, you want me to write something? They just deny it, just to deny. A lot of times it makes no sense. The other piece of it is, since we're not dealing with insurance, that I practice medicine the way I believe, not what insurance is telling me to do. So you go through medical school, you go through residency, you learn to practice, and then you get into real practice and you learn a whole different way to do it, because you have to satisfy insurance. And prior authorizations are the big issue, that they won't approve whatever study or whatever procedure unless you've met all the steps in their algorithm. One of the really common ones is for orthopedic injuries, either chronic or kind of, subacute. If you don't document 2 weeks of ibuprofen and 4 weeks of PT, you are never getting an MRI. That's just how it is.
Really?
Absolutely. That's no getting around it. It's been a couple of years ago, we had a patient, she came in, history, physical exam, she had a torn meniscus. We got the MRI done that day. She saw ortho the day after, and she was in the OR that following week. The guy that did the procedure, this friend of mine, he called me afterwards, and he was like, man, I got to tell you about the case afterwards. It was an old guy that he'd had a foreign body in his knee, been there for years, but had gotten somehow, trapped and was causing him a lot of pain. They prior authed the whole thing. And then the day of the surgery, it got canceled because he hadn't done PT yet. How are you going to PT a foreign body out of your knee?
Yeah.
The insanity of getting things approved, that is a piece that I do not miss in the slightest. That when I need something, I just do it. I don't have to ask permission. And that's, if you practice, one of the, phrases I like to hang on to is, good medicine is cheap, bad medicine is really expensive. That just practice good medicine.
Yeah.
And the cost will fall in line. If you're worried about the cost, you practice bad medicine. Just practice good medicine. The costs follow.
So in the traditional model we've all kind of been operating under, we got to have insurance for health to get any type of health service. Yep. So how does it then work if you, in the case of that patient where she needed a surgery, how does then that work on the back end? And then is there any penalties for not having insurance on the grander scale?
Right. Well, in her case, so she was an employee of a company. So we're kind of split. We have I refer to as retail patients, individuals, and sponsored patients. So we have companies, a little bit larger companies that they choose to go through a self-insured model. And our type of practice plays really, really well with self-insured. When you're self-insured, your risk is claim costs. And we reduce those claim costs. So it's going to end up working out well for that company.
Welcome to the brand new Falaya mobile app. We took all the same tech that's helped hundreds of people sell their homes themselves and packed it into an easy-to-use app for your phone. When you download the Falaya mobile app on either the Apple or Android App Store, you'll immediately be able to see the power of this game-changing tool. From the seller's dashboard, you can navigate to all the information that you need. We intentionally separated everything into key groups, such as tasks to be completed, buyer leads for your listing, and contact information for everyone involved through closing. When you get an offer on your property, you can simply review and respond all within the app. No matter where you are in the world, you'll be able to monitor everything that's going on with your property from listed to sold. It's truly the power of Falaya in the palm of your hand. Download the app and see for yourself. Falaya, it's real estate reimagined.
What we started focusing on in the last year or so is the smaller companies. So if you have more than 50 employees, you're legally bound to have an ACA compliant plan or to self-insure. If you're under 50, you're not. But there's a lot of companies that want to take care of their employees or also recognize the benefit for retention and recruiting of having some type of health plan. So we have companies, in that size as well. She was an employee of one of the companies. Mm-hmm. So for an individual, we're covering, a lot of times 100%, but others, 95% of the healthcare needs. But, I can't take your gallbladder out. So right. If you need to have something, and what we see is, folks will do, high deductible plans, and really they're using us for the convenience, the care, the continuity. We've really started trying to point a lot of people to health share. You hear a lot of it, or at least I hear a lot on the radio, and, they're good plans. But, one that we really like, it's called Zion Health Share. And why we like them is it's true major medical. So they're not paying for office visits, routine office visits. They're not paying for medication. They're not paying for labs. But we can do it cheaper than they can do any of it anyway. So they're paying for, the surgery, the hospitalization, the pregnancy, malignancy. And their rates are very reasonable. They're age-based. So at the lowest age tier, it's $85 a month. And at the higher age tier, it's $229. So we don't really want patients without insurance for those, high cost issues that may come up, or, if they have some chronic, issue that's going to require subspecialist care that it's outside of my scope. Right. So we get calls like that all the time, and, that's not, really what we want. So the vast majority of our patients have some type of backup healthcare, and like I say, a lot of them are employees of companies that we're part of their health plan.
Yeah, it makes sense.
Yeah.
So going out and doing this on your own is a big shift, right? Like you're going, even though you had that little stint with another doctor, like that's still a big shift to go out and do it on your own. I mean, what was running through your head when you're like, am I really about to do this thing?
It's I get calls from physicians who hear about it and are interested, and would like to be able to practice this way. And, they reach out, and that's my general response is, are you ready to jump off a cliff? Because if not, this is probably not for you. That there is no salary. There's no backup. There's no revenue, then you're not getting paid. So it's a big leap, for sure. But, where I am now, there's no way I would go back. That I so much more enjoy what I do now and how I'm able to practice and how I'm able to drive how I practice, that, it was worth it. But I don't know. I feel like I may have blacked out for a few years there that I don't remember some of it. The way I've really kept things afloat was I worked as a hospitalist, but in Lafayette.
Okay.
Was able to make a little more money doing that. So it was get up, drive to Lafayette, round on patients there, and then come back and run my own clinic, and dealing with all the business side of it. And it was some long days.
Right, because it's on the business side, you're not necessarily given or taught that set of skills in med school.
You're not taught at all. And most physicians are not going to be involved in the true business side. The vast majority of physicians now are employed. Yeah. So they don't, see that side of it, but there is still a business side they all experience and that they don't understand. And that's one of the really difficult things for physicians coming out of training. I've thought before that, something that would be of, I think, real benefit in residency is that the residents bill. It's still going to be, co-signed by an attending, and they're paid a percentage of that bill, a small percentage. But when you understand that if I do things this way, and not really about patient care, but a lot of it's more just about documentation, then I'm paid this much. And that means the difference between, getting the caniac versus, the three finger today, that you start understanding this stuff matters, because they don't realize that until they get into practice and it starts affecting their income. That learning that early on, I think, would be a huge benefit of. And again, it's not about the patient care side of it. It's really just about the documentation side. And they're not as thorough. They don't understand what they're doing, and they kind of learn by trial and error once they get into actual practice. The business side of it, yeah, like I say, most physicians are employed now, which is a shame. Private equity coming into medicine, I think, is caused a lot of the problems that we see. They're trying to make a return, they're trying to increase, value of that entity, and patient care is nowhere in that mix. The business side of it, that was those were hard lessons, that I've learned some tough ones.
Yeah.
That I look back and I'm like, God, I did not know what I was doing. Probably still don't, but I've really had very little understanding. Right. I went to recently, Stuart Gillies doing this business education thing, and I went to one of their presentations, and it was very good. But I was like, man, 5 years ago, I wish I'd have been sitting in this room, because there was not a lot that was said that I don't know now. But I had to learn it by, difficult right. Mistakes.
Trial and error.
Yeah. And, I was like, man, having, these talented guys kind of give you the roadmap. Jeez, I would have given anything to have heard that a long, long time ago.
Yeah. Well, I mean, like, prime example would be you're coming from an environment where you've got so many patients you're seeing. It's just about the number, right? And then there's a standard model that's a standard. Okay, you go to a doctor visit, you bill this much, insurance covers. All those is a formulaic relationship. When you switch and you kind of flip the model upside down, and now you've got two elements of your practice. You've got the monthly retainer portion, which they're going to pay. Hey, you're going to pay a part this month. It'll cover X, Y, and Z. You don't have the routine, oh, you come and see us, okay, it's going to be, you're going to have to get charged an extra amount. No, we bill all that in there, but then if you have anything extra, then you have your a la carte menu, so to speak, that you've got to come and pay off of. Like,
Well,
how do you work through the pricing of just the monthly piece? You know, like, you don't know if I'm going to come and see you 10 times or never.
Well, so that's I'm glad you said that. So for us, because we don't bill insurance, that is the only, as far as just for visits, that is the only fee.
Okay.
You don't pay anything when you come for a visit. So your monthly fee includes your visits. So there's no bill whenever people just come to the clinic. And, one of the things that, people initially don't appreciate, and then after they're with us for a little bit, they do, is so you can't submit a payable bill to insurance unless there is some component of a face-to-face encounter.
Okay.
You got to see a patient. Nowadays the telemedicine, it counts. It's not as valuable. There's not as much revenue to it, but there is some reimbursement. But you have to see the patient. I don't bill insurance, so a medication refill, I don't need to see you. For something very simple, I don't need to see you. So patients either call or we have a secure messaging. And if I don't have a medical question, I have no incentive to make them come to clinic.
This episode of the Patty G Show is brought to you by Cortex. Cortex is the trusted technology partner for small businesses across Louisiana, delivering managed IT, cybersecurity, and smart strategies to help you leverage AI without the confusion. I mean, aren't we all confused by AI nowadays? As a locally owned company, we understand the challenges Louisiana businesses face and provide tailored solutions that keep your operations secure and efficient. Whether you're looking to strengthen your cybersecurity or explore how AI can give your business a competitive edge, Cortex is here to help. Be sure to mention the Patty G Show and receive a free cybersecurity risk and analysis to see where your business stands.
For something
you need
routine.
to put your eyes on.
Yeah. There's absolutely things that I'm like, I need to see this. I need to do a physical exam. I need to hear this from you.
Yeah.
But there's a whole lot of things that it is not. Previous practice, if you call in too many scripts, you kind of get a warning.
Really?
We got a bill. I can't speak to everybody, but the general model with most multi-specialty groups is you're not being paid directly from your billing. Your billing, affects your revenue, but in a simplistic way, you can kind of think of, and it's really how you make the model work. Everybody puts their revenue into a pot. And you're paid really an incentive-based salary. And the value of doing that is, in the end, really, internists, primary care, likely get paid more than they generated in revenue. The proceduralists probably get paid a little less than they generated in revenue. But the direct referrals, keeping it in the family, increases the entire pot. So it's not, hey, I billed this amount of money, that's how much I get paid.
As a whole,
most groups, you're really on a salary.
Yeah.
There's some incentives built into it. But you're not, being directly, you're not eating what you kill. It's kind of going into a pot and then you're paid out from it. So it kind of separates a little bit just from the direct revenue of it.
Yeah, it's different.
Yeah.
So when you're, first getting started and you work through all that and you're meeting with people, you're kind of explaining to them a whole different way to go about their healthcare. How do those conversations generally go?
So two of the things I've had to learn to adjust with businesses, what's your elevator pitch? Mm-hmm. And there is not one. It's the shortest version I've come down to is let us take a look at where you are and where you want to go, and if we're part of that solution. And that's about as short as I can get, in that it's a complicated question. And, for the businesses, we're not the answer for everyone. So we're evaluating them, that we go through an underwriting process. I have strategic partners that kind of, it's a turnkey approach. So we have, the broker, we've got the, third-party administrator, pharmacy benefit manager, repricing company, all of that to come in and, fully replace their plan. But, when we're looking at them, if we have somebody that does not succeed with this, that's bad for them. It's really bad for me.
Right.
So if it's not a slam dunk, we're not interested. So, we're very short with them of, I don't have anything to propose to you yet. Just let's take a look here. Where do you want to go? And let's see if we can help get you there. And maybe we can, maybe we can't. With individuals, the common response we get is, what's the catch?
Right. What's the catcher? Man, this seems a whole lot more expensive than what I'm paying now with my existing insurance. And
it's there isn't a catch. It's that insurance is it's that complicated and difficult. So, that's a lot of times folks are like, well, I have insurance. Well, sort of. The analogy I like is, if we treated auto insurance like health insurance, what would that look like? Okay. So if you went to Exxon tonight and pulled out your insurance card and ran it and didn't pay anything, and when you went and got an oil change, like, well, this is all my insurance. And when you change your wiper blades, this is all my insurance. We get how asinine that is. That insurance is for, car insurance is for when you get in a wreck. It's for something catastrophic. Somehow we morphed into health insurance should pay for every single routine medical health care cost. If you went to Albertsons tonight or Rouse's and got your groceries, and the next night you had Uber Eats do it, why would you expect Uber Eats to be cheaper than when you did it yourself? It makes no sense. Mm. But then we look at health insurance and somehow expect it to be that way. Well, no. You're paying these massive organizations to basically pay your healthcare bill for you, your routine office visit, your medication. They're not doing it for free. So how could it possibly be cheaper than if you just do it direct?
Mm. So then do you work with people to scale back their insurance plan?
So,
like, if I've got a plan that's covering my prescriptions, that's covering my doctor visits, do you then work with them to scale it back, or like, how does that?
If they're able to, okay. And that's where for, generally healthy people, that's why we love the health share plans, because they don't cover those, and that's great, because we do. For folks who have an employer provided plan, a lot of times they're fairly locked in. The issue being is just, what's it worth to you? That, waiting a month to see a physician, sitting 45 minutes in the waiting room and then spending 9 minutes with a doctor, what's that worth to avoid? And having somebody that is truly spending time and evaluating what's going on. Like I say, before I was one patient to the next. In our practice, when we have a new patient, we set aside an hour and a half. So I have time to look at their medical records, understand them, what do they want to do, where are they trying to go. Follow-up visits, we set aside 45 minutes. I would see 6 patients in that time in a fee-for-service practice. So I'm able to catch things and, really pay attention to what's going on. Practice like most guys would like to practice. They're just, they
just can't.
They just can't. I'll see new patients and I'm looking over their chart, and I've learned to be very careful how I say things. I'll just see egregious mistakes.
But it's not any fault of their own.
Doctor.
They got 9 minutes.
It's the system,
right?
And I'm like, it is. He's a good physician.
Yeah.
It's nobody can process data that fast. Well, it's not possible. So just, a lot of basic things just get missed. And that's just, it's the nature of the system. So, what's your healthcare worth to you?
What's your health worth to you?
Right.
Yeah. No, I mean, it's true. Like you go and you sit in the waiting room for 45 minutes to an hour, and then you're in there and you're in and out so quick. Yep. And really only with the doctor, like the nurses are doing so much more, and the doctor walks in, all right, yep, okay, yeah, you're good, go home.
Yep.
And it's like, what was this for? And then to your point, if you need a prescription, you need anything, you've got to go in, you've got to see them, and it's a complicated situation.
Absolutely. And that's, refills, it is what it is. Again, it's the system. It's not the guys that, each clinic has their policies of how recently do you need to have seen a patient to write a refill. And there's nothing, legally or medical ethics that drive any of that. That's revenue based. That if I haven't seen this person in a while, then I'm not going to write a prescription because I need to get a visit.
This episode of the Patty G Show is brought to you by Cortex. Cortex is the trusted technology partner for small businesses across Louisiana, delivering managed IT, cybersecurity, and smart strategies to help you leverage AI without the confusion. I mean, aren't we all confused by AI nowadays? As a locally owned company, we understand the challenges Louisiana businesses face and provide tailored solutions that keep your operations secure and efficient. Whether you're looking to strengthen your cybersecurity or explore how AI can give your business a competitive edge, Cortex is here to help. Be sure to mention the Patty G Show and receive a free cybersecurity risk and analysis to see where your business stands.
No, it's a fair point for surveillance labs, but do you need to see somebody to order labs? No. But yeah, you got to go in and pay for the visit to get your refill.
Yeah. And then pay for the refill.
Yeah, and pay for the refill on top of it, which that whole scene, I mean, the medication costs are just, it's outrageous. And when you really get into, you see, kind of behind the curtain on some. So one of the things with the sponsored companies, with all plans, they don't cover over-the-counter medications. We require them to cover 2 classes of medications. PPIs, which are like for reflux, and antihistamines.
Okay.
The markup on those medications is obscene. For like Nexium, you go look at at Costco, what the cost is. The price per pill is, a fraction of that. So we write it as a prescription and fill it in clinic. And I guess I realized I haven't mentioned with the sponsored with the larger companies. Part of their health plan is so they're paying the member fees, so the patient doesn't pay anything when they see us. They also pay 100% of prescriptions that we dispense. They pay 100% of labs. They pay 100% of the imaging. So patients pay nothing for that. So when they get a prescription from me, it doesn't cost them anything. So that's why we will write those over-the-counters, those two classes, just that I know what it costs if they go to Walgreens, and I know what it actually costs. And it's just crazy how much, thousands of percent that those things are marked up.
Wow.
And, with a lot of the newer medications, these biologics, they're insane. $20,000, $30,000 a month for some of this stuff.
Yeah, and I've seen it's just like prescriptions for people are off the charts.
Well, and the crazy thing is, if you're on a typical plan, a Buca plan, you're prevented from obtaining medication internationally. When you're self-insured, that's not true.
Okay.
So that's one of the approaches we look at with those high-cost medications. And the difference can be, astounding of, 30,000 versus 2,500 to get from Canada or Australia or Britain.
Which is interesting because aren't they manufactured there?
It's the same exact thing.
Aren't they manufactured to begin with over there?
I didn't get a chance to read the whole article, but I saw a headline today of one of the big pharma companies with a new release medication that they're doing universal pricing internationally.
Okay.
And that's the whole issue is we're basically subsidizing other places by paying outrageous fees, and then in other countries it's so much cheaper. Well, we're paying the difference, so just charge the same fee everywhere.
Yeah, some places you've got more of a loss leader model where they're trying to get the medication to help the people, and then here we can afford to pay the markup, right?
Right, exactly. So it's like they charge, basically making up the margin here for what it really costs, which they sell elsewhere and then sell for cheaper, in other countries that are, not as fortunate.
Yeah, which, great to help those folks, but at the same time, to what end?
Right.
At what point is it going to get to that level bill?
Yeah.
Because they're not hardly ever made here.
No.
They're made somewhere else and then imported, and so it's the same thing as foreign medication. It's it's not foreign is it really foreign medication?
Nope. Yeah, no, that's absolutely true, and that is with in the last few years, I think there's become more awareness of how limited our medication production is in the U.S. and what a liability that is to us of we're dependent on other countries for a lot of the medication production, so hopefully some of that will change.
So in kind of growing your practice, is it just you? Do you have more doctors? How does that start to work? Because you only got your 300 to 500 patients, right? Which is a respectable amount to maintain per doctor. Do you have multiple of you? How does that work?
So direct primary care is not new. It's been around a while. And time flies. I don't know, 10, 15 years ago, it was the answer. And a lot of big money got behind it. Jeff Bezos was a big investor. And it flopped. There were three kind of bigger groups that really grew and grew fast and did not work. And so the consensus was the model doesn't work, and people gave up on it. But there was physicians out there that still believed in it and stuck with it, and demonstrated the model does work. But the next thought was, well, it works, but it doesn't scale. And over time, there's guys that have proven that's not true either. So the question that's hanging out there is, how far can it scale? Because I believe there is a finite limit in that, again, we're not trying to increase revenue. We're trying to fight overhead. And at some point when you scale, overhead's your problem.
Right.
So I think there is a scale issue, but it's not one clinic or two clinics. That I've visited with some guys, around the country who, they're, 12, 13, 14, 15 clinics and are not running into that limit yet.
Yeah, that scale issue.
So, for me, that's a daily question of, do I want to just have a robust clinic on my own, or, and kind of how I phrase it to myself is, do I want a clinic or do I want a business?
Right.
And I go back and forth. Honestly, the biggest draw to being a business versus a clinic is I know what a benefit it is to small business owners. And if it's just me, there's not much there. That's probably the thing that makes me, contemplate it the most. With guys in the state who've expanded, again, I say I have people call and I'm like, well, there's no salary. That's just become the expectation for physicians. A lot of times nowadays, you have guys that are in residency that have already signed with a clinic and, some of them getting paid stipends. And, you get out of residency and you buy the house, you buy the car, the kids start school. And, at that first year when you're like, man, I don't like seeing all these patients all the time, you're stuck.
Well, yeah, your banks are lending based on the output that you're going to perform.
Yep.
And it's been so intriguing to me how quickly banks can lend to the medical field.
So there's a lot of banks, and one of the banks I use, they have had a wonderful program with it. That the biggest piece of it is that they are able to exclude student loan debt from your debt ratio,
which is interesting.
Yeah. So they're specifically healthcare mortgages, and being able to take that off the personal balance sheet helps a whole lot in qualifying for a loan.
It does, but it's still there.
It's still there.
It still on your balance sheet. They're just not looking at it. In fact, they remove it from the equation, but it doesn't mean it's removed.
It is still there. It is still there for a long time. So it's, but yeah, it's, I said, people will have, ask about their kids and going to med school, and, if it's a passion, great. But
yeah.
I think, what makes a good physician is a mix of that you would like to be financially rewarded, but you want to contribute and help people. If all you want to do is help people and have no interest, I don't know, be a missionary maybe. If all you're interested in is the financial, remuneration, then you should go into business. And you come out of college and you spend the time and effort and study at a job that you would spend in med school and residency, you'd be light years ahead of most physicians coming, 7, 8, 12 years out of virtually, zero revenue.
Right.
That you're not getting paid in med school, and when you're in residency, you're getting paid minimum wage, basically. We calculated one time based off the hours what we made per hour, and it was very depressing when you realize what you're actually getting paid.
Yeah.
So Yeah, they've been, all this time behind their peers and who've, been buying houses and starting families, and they've been waiting for that. And so, yeah, they're able to get loans to kind of accelerate that. And, I see the temptation for it.
Right. Very tempting to do it.
And nothing wrong with it. And, you've, got years of financial earning. That's the one downside. One of the downsides is you can't make a career change. You can't make a change in really what you're doing to shift to a different model, because now you got that mortgage, now you got the car payments, all that, and you need the revenue.
Yeah, or you got to be frugal enough,
right,
to be able to make the change.
Yep. There's in Louisiana, I've visited with some folks who've started additional clinics, and they've really looked to bring in physicians that are just coming out of residency for a lot of reasons. That one is they're trainable, that they haven't gotten so pattern oriented by insurance yet, because that can be hard to break. We have to do all this. Well, no, you don't.
Yeah.
Says who? And they're not. I was talking to somebody last year that her approach was, she was like, look, think of it as a 4th year of residency. I'll guarantee your salary will at least equal to what a 4th year resident would make. And if you exceed that, that's yours to keep.
Mm-hmm.
But then a year, you will have built a practice that other people wish they had. So even if all you make is just that 4th year resident salary, and she's like, and she ended up doing better, that's your floor.
Yeah.
And what is that worth to not be stuck in a job that all you're figuring out is, when can I retire? Because this is not fun.
Right. So as we kind of start to wrap up the show, we have a set list of questions we ask every guest.
Sure.
So the first one being kind of looking back at your childhood and upbringing and everything. And that is, what is something that you did as a kid you wish you could still do today?
Read more. I like to read. And, a lot of times at time and then at night, I'm just like, let me watch mindless TV. When we were at the beach this summer, and just sitting down and reading a novel and some nonfiction, I wish I had more time for that.
Yeah. You've kind of been through a lot, seen across different models. And now that you're in yours for the last 5 or so years, what have been like 3 lessons you've learned along the way?
Loyalty to the patients, that they are a customer as well. Loyalty to my employees, that the value in them is, that's a lesson I've really had to learn, is having the right people and understand your numbers.
Yes. Numbers are key.
Numbers are key. It's wonderful to have concepts and have ideas, but I've learned, and as of now, I have a CPA that certainly guides, but I do my bookkeeping because I trust no one, and I've learned and I understand it. And the value, so I had someone a few years ago, someone very successful, that we were talking, and he said that when he gets up, the first thing he does is he does his books. And, I was in a habit of, I'll do it, all at once. And then, a week goes by, 2 weeks go by.
Mm-hmm.
And when I shifted to that, one, it helped to, keep the books where they're supposed to be, but it gives me an understanding of what is going on with my business.
Right.
That when I look at the numbers, when I understand, like you said something about medication earlier, medication is a commodity like anything else, with a variable price. So, one time when we order lisinopril, it's this price, and the next time we order it, it's a different price. And it can really, really shift dramatically. And if I'm not personally looking at that daily, then, when I'm just looking at, balance sheet and a P&L, I'm like, well, I see this has changed, and maybe even in that category, I see the difference, but I don't know why.
Right.
And so knowing the numbers, that's something that I've just become very passionate about, and I enjoy, actually. I kind of like doing it, so it'll be a long time before I turn that over to somebody.
I love it. Yeah. So what is something you love about Baton Rouge?
People. I grew up out in Livingston Parish, but I consider, Baton Rouge home. And, after college, moving away, I lived in some great places. The longest place I ever was San Diego. And, for, tactical training, we flew at night mostly. And so it shortened our crew day. So, we would go in, 7:00 in the evening and fly, and then, debrief, and we're done, 2 or 3 in the morning. And then the rest of the day we got up, we lived right on the water. We go down and surf and hang out. And, but it wasn't home.
Yeah.
It would have been nice if San Diego was home to me, but it wasn't. And, you're not going to run into people that you haven't seen in 20 years. Right. Elsewhere. And so just, the people, is what makes this home to me, and, why that's really kind of, where our base is.
I love it. So what is something I can do to help you?
Share our message. It makes it easy to be passionate about something if you believe in it. I don't think I could do something that I don't really believe in. And I'm not a natural salesperson. That's not my wheelhouse. But that's, sometimes when I get anxious about that, I remind myself, a lot of times I'm giving somebody a gift.
Right.
That if they were about to be hit by a bus, would I not yell, "Hey man, get out of the way of the bus"? And their business is about to get hit by a bus. So, we just want people to know we're there, that if we're a fit for them, we'd love to help. If we're not, no worries. But it's, people just are not aware. And, with businesses, a lot of the times the challenge is, it's something people don't want to really think about. And, they rely on advisors, brokers, and a lot of times they're not very interested in our model. From the broker perspective, our model, especially with self-insured, is more work and less money.
Right.
But it's to the business's detriment. So, that's letting people know we're out there, and just that, we would love to help folks just navigate that, because it's, it's a shame to see what a lot of businesses go through with that one, expense of healthcare.
Oh yeah.
Or can't provide it. I visited with somebody today that, that's been one of the most refreshing things, from when I started this was, I have yet, maybe I will, but I have yet to meet with a business owner whose first priority was, how can I save money? It was, how can I provide something better for my employees? And honestly, I didn't expect that. I was focused on how we could save them money. And, after hearing that over and over, it really caused me to pivot to, you can do something great for your employees and probably save money too.
Yeah.
But that's not their primary goal. And that was a welcome surprise to see that. Just of that, there's a lot of guys, they start a business, they care about their employees, they think of them as family, they just want to do right by them.
Yeah, they want to do right by their team.
Yep.
Well, thank you so much for coming on the show.
I appreciate it. It's fun.
Appreciate your time and coming and sitting in the studio with us. So thank you, and thank you everybody else for listening or watching, whatever platform you're consuming us on. Take care of yourselves out there and check in on your health. We'll see you next week.